thanks for having me today. It really has been a terrific day, and you know, I've always wanted to go to the University of Chicago, so it's nice at least to come here. Still waiting for their answer. Okay, well, cheaper, better, easier access is, that's what we all want, and somebody articulated nicely that, we've tried a lot of things for a number of years. So what makes us think this round will be any different? I do think potentially with big data, we're at least a lot better equipped to try harder. And that's saying something. With EMRs, we are seeing a tremendous amount of information that we didn't have before. There's always been a lot of talk about value-based contracting. If you find one, would you send an example to me? They're just not out there. Occasionally you'll see a value-based insurance design, and we have, dabbled in that as well. Value-based contracting on the provider side, there's been certainly a select different models. But really, anything meaningful, raise your hand. There's not a lot. And so in many ways, we're not all on the same page. And we can't be on the same page because nobody knows what the other one's doing. But maybe with this big data, if we use it properly, we can get there. And I wrote a growing willingness to across the stakeholders to collaborate and share data. We're going to be forced to do this. Just the economics of this. The healthcare data, we put out the United States of Diabetes in 2010, articulated that, over the next decade, it would be a $3.4 trillion issue to this nation between prediabetes and diabetes. And that number would do a lot to reduce the healthcare deficit if we attacked it. But it has to be coordinated, and we all have to be on the same page, and nobody is. So, but I think that, again, with big data, and you are seeing collaborations, folks come together, as you know. We spearheaded an effort to bring together a number of large payers' data through the Healthcare Cost Institute. It's an independent entity. Yes, it is funded by the payers, but has its own board, make their own decisions. Medicare data is into the set, and you have academicians now being able to access a very large data set across payers, across geographies, and to sort of begin to answer some of these questions. This is just a picture of how it might all come together and how we all might come together to collaborate. You've heard today, some efforts about patient-centered diabetes care, and the spirit of value-based insurance designs. And as many of you know, we rolled out, I think in 2009, a diabetes value-based insurance design specifically. And a couple of learnings there. One, make it opt-in, not opt-out. And it's interesting, when we did that, very few people opted out. Who wouldn't want a benefit that says, if I comply with or I adhere to evidence-based guidelines, not even to outcomes, just to process measures, I will have a significant reduction. I'll have zero copays in my out-of-pocket expenses for diabetic-related care. It was very accepted by patients throughout a number of health plans, and, drum roll, compliance improved. Now where'd she go? The last speaker. Where did she go? Oh, okay, her too. Okay, so she didn't change. It looks like, it's early and we're having it formally, externally evaluated, but it's not 100%, but it is significant. And what will be interesting is the way that plan works, year one you're in. So year one, you get the enhanced benefit, which the actuarial value of that is about $500. That's how much extra copays people living with diabetes pay compared to people like me who don't have any chronic disease, digging in the pocket for all those copays. Year two, your benefit, your continued ability to enjoy that enhanced benefit is based on what you do as an individual. Did you get your hemoglobin A1cs? Did you go? And they're pretty simple, and nobody disagreed with the measures we selected. And if you choose, because we're Americans, if you choose not to do that, that's okay. You're out for year two, and you go back to whatever plan everybody else in your friends have. And I think it's going to be interesting to see how you can earn the right back in for year 3. So in year 3, if you do year 2's gig, you can get back in. So that's really what I want to see. Yeah, we increased compliance in year 1. I'm really curious to see how many of the people who left in year 2 come back in year 3. So I did want to sort of talk about value-based contracting, and I was sort of glad I was going last because I can run to the door. It's the whole idea that we're going to all economically. So I think in many ways with the health insurance design, we're sort of trying to get patients and consumers on the same page. But we have to get on the same page with device manufacturers, the pharmaceutical industry, surgical supplies, et cetera. And we all have to say, you know, well, who's it working for? You know, do we as taxpayers want to pay more if it's not working? All of you who do, please raise your hands. Right, I don't either. I don't mind paying more if it actually works. And the challenge we're going to have is it has to work for me. That's right, me as an individual. So why should I take a drug that costs 10,000 bazillion more than metformin if it doesn't work? I might as well take good old cheap metformin. Maybe that's not working either. But I don't want to pay as a payer more for stuff that doesn't work. And I don't want to just see a single clinical trial that sort of got you through the FDA process. I want to say, almost like post-drug surveillance. Let's see that if I go on this new fancy-dancy pump, am I actually either getting to target or reducing hypoglycemic events? Those studies are not done. And you know what's interesting? We have the data. We actually have the data. I can tell you that answer. I just never looked. I'll tell you, I recently looked on one of these issues, and I was really surprised. And I am a pediatrician. I was really surprised. I just figured people who went on the fancy-dancy drugs and devices, they actually were doing much better. It turns out it's not true. Now, I don't know why. So that's interesting. Some people do, but some people don't. So maybe after 12 weeks of getting on new drug or whatever, maybe we stop and say, we got to try something else. It's interesting, when you have cancer, that happens all the time. So I did train in pediatric oncology. If it stops working, we find plan B for you. We have to find plan B. We at least have to try plan B. It's that critical. And I think the same thing in this area. This is an example. I actually cut and pasted this. This is in one of our contracts. It's on the services side, I'll tell you that. And that is, okay, well, we will pay more if you get them patients to target. That makes sense, doesn't it? You know, and I thought this was reasonable. In fact, I had somebody externally over at Northwestern help me. I said, well, that's what would be reasonable. So yeah, get to 7.5 or reduce by 10%. I think I think there's another line that says the hemoglobin A1c can't be higher than I think it's 12. So we didn't want to pay extra to go from 16 to 14. But this is reasonable, and we're going to see how it works out. As many of you know, that we rolled out the diabetes prevention program with a number of, I want to see what I know I have. Oh yeah, actually I'm going to go to this slide first. I'm going to go back to that one. So this is another sort of, I'm going to go in a different direction. Somebody said plans don't like paying for devices that maybe help adherence. Differently, plans don't like to pay for stuff that's not proven to work. And I think that's fair. And I actually, as a taxpayer, as a shareholder, I'm into that, But we are absolutely willing to see, what will work. And did any of you see Richard Bergenstall's article recently about the whole ambulatory glucose profile? Isn't that fascinating? I didn't realize that each meter, et cetera, puts out a different kind of picture. Those of you who are my fellow physicians, I mean, we can pick up an EKG, whether it's put out by a Philips machine, a GE machine. The EKG thing it's the same. We all know how to read it. They've agreed on standardization of what that output should look like. Turns out that's not true for many of the readings. So isn't that interesting that you could create an ambulatory glucose profile that perhaps if all the manufacturers got on board, then we all could speak the same language. Right now, I'm speaking English, you're speaking Greek, and he's speaking French. Well, how are we going to standardize and sort of get to best practices in that model? It was very encouraging to see the FDA actually came out and commented. They didn't actually support his particular model, but the idea that we as an industry should come together. And maybe we as payers can support that issue by saying, maybe in 3 years we're going to only pay for people who have a standard glucose profile. And to this point, I'd like to talk about, hemoglobin A1c, and I get that it's all the, quote, stars are aligned, little pun, but I feel, anybody here know what Moodle is? Come on. Thank you. Thank you. No, Moodle? Anybody here, okay, so it's the system that you as a parent can go online every single night. Anybody now know what I'm talking about? Okay, thank you. So remember the good old days when you got your report cards? And if you got a D, your mom said, "What happened?" And you say, "I don't know." So then what do? You wait till the next quarter, and you get another D. And she says louder, "What happened?" And you don't know. Well, now, the education world, isn't that interesting? Every night, you can go online at every school almost across the country, and I can tell whether the homework's done, the test, the quiz, the projects, participation, that's my favorite. But at least I have a sense now, I'm not surprised at my average D in 3 months. What does that sound like? Hemoglobin A1c. So wouldn't it be great if instead I did have, and again, I'm not promoting any particular methodology, but wouldn't it be great if I had an understanding as a type 2, isn't that weird? Every night, or I seem to like blip at 8 o'clock. What am I doing at 6? Oh my God, I drink beer at 6, or I drink the beer and the chips while I watch football. Isn't that interesting? So then I would have that daily information in some sort of form in a way that we all understand in English, that we could actually react to that. In my D kid case, it turns out he didn't like to do projects, So we worked on getting those projects done. So, and I'm going to go back. What time is it? Okay, yeah, 2 minutes. Great. To this, as many of you know, we rolled out with the diabetes prevention program with the Y and the CDC, and that's going very well. I'll tell you that there's been about 15,000 people who've gone through the bricks and mortar program. I say that's about 10,000 people who potentially did not convert to full-blown type 2, or at least, haven't converted yet, and we're thrilled about that. But 79 million people have type 2 prediabetes. We're so proud of our 15,000. What's 79 million minus 15,000? Yeah, 79 million. So we went to Plan B, and not Plan B, we went to Plan A plus B. And B was we worked with the Comcast Corporation to say if we could deliver this through the television and support with social media, et cetera, the groups, everything. And we actually created a reality TV show of people going through the DPP, and then offered people living in Philadelphia and Knoxville the opportunity to participate in a study where they would go through the DPP by watching the reality TV show, and then blog and chat with their coach online, be supported, think Facebook, et cetera. And we're about to publish that, and I'll tell you it went very well. But for this conversation about engagement, I found one of the most fascinating things. How many of you have done a clinical trial? Okay. If you needed to enroll 350 people, and there were some criteria, I won't go into it now, but you can read about it. How long would it take you? About 350 people. Long time, years, right? I'm thinking at least 2 years in my experience. We did public service announcements, and we actually had NBC and Comcast develop them. So they were very professionally done, and they used professional actors. 2.5 weeks. 2.5 weeks for everybody who met criteria. So talk about engaging people. And so I only tell you that, so here we are, the nation's largest health and well-being, and we are partnering with the entertainment world because we must. And you know what? They did a great job. I couldn't believe it. 2.5 weeks. And by the way, 1,000 people called. 1,000 people called when they saw what we did was a series of 4 public service announcements. First, we talked about what prediabetes was because most people didn't know. And then the last one was a call to action. And the really exciting part was that we didn't want somebody's earlier slide. I didn't want all white women. I'm not opposed to all white women. I mean, I'm not opposed to being an all white woman, but we didn't want that. That's not our target demographic. And so what we learned from them is we can put the PSAs on during ESPN, during football. You can put them on certain television stations, and guess what you get? The people who watch those stations. So a tremendous learning experience. We are absolutely now rolling this out, both for our own fully insured and a number of large number of large payers, and to show you that now, interesting that these folks now will pay for the service that we couldn't have imagined paying for even 5 years ago. So I'm going to stop there.